Uh, very good evening to all of you. I welcome you all for the last academic session by the Cerebral Palsy SIG. We will continue with the second part of understanding cerebral palsy, a lifespan perspective. It's a panel discussion with seven eminent panelists. I have to request the President, Dr. Shapadi Gulati, to introduce the panelists and the experts today. Over to you, ma'am.
Thank you, Mahesh. I welcome you all for this SIG, this thing for CP, and we had planned that we are going to do the multidisciplinary management part, and the multidisciplinary management. We did the orthopedics and the interventions earlier, and this time we'll be covering the rest of it. Can we have the CV slides, please? So we have Dr. Nagendra Kumar, who is Consultant Director, Pediatric Gastroenterology and Hepatology, Manipal Hospital, and Honorary Consultant, Indira Gandhi Institute of Child Health, and with a lot of experience and awards in pediatric gastroenterology. Next, please. We have Dr. Viniti Puri Srivastav, who's a speech and language therapist and clinical director of GIGS in Communication Center. And she has got her training and was practicing in Singapore earlier. Can I have the next, please? Dr. Vandana Jain, who's my colleague, would be joining shortly. Is a professor in Division of Pediatric Endocrinology and has a lot of laurels to her credit. Next. Dr. Meghanand KR, who is MS from PGI and Managing Director, Ma ENT Hospital, Hyderabad, and has been doing a lot of cochlear implants and lots of robotic surgeries. And thank you for joining. Next. Dr. Sanjukta Day, a Senior Consultant Pediatrics and Unitology, Peerless Hospital, Kolkata, with special interest in respiratory. And it's a very well-acclaimed pulmonologist. Next. That's all. So Manas, yeah, Dr. Snehal Ganatra, she's consultant pediatric and neuro-ophthalmologist at the LV Prasad Eye Institute, Visakhapatnam, with a lot of interest in the pediatric complex cases. And next. Dr. Roshan Bhupesh Kore, nutritionist, a registered dietitian with an experience of 3 decades in pediatric nutrition, and she has worked in hospitals like BJ Wadia Hospital and NHISRCC Children Hospital, Mumbai, and founder of NutriKids Pediatric Nutrition Center. And we have the moderators would be Dr. Raju, who's the co-convener of this subsection, and alumni from our place, and very nice to see our students coming up and becoming so senior, but then that makes you feel so elderly actually on the other side. And Dr. Diptanshu Das, who will be the co-moderator for the panel, and he is the secretary of the SIG of cerebral palsy. Basically, the point is, the idea of having today's panel discussion is that most aspects of care of all these specialties in cerebral palsy children are actually neglected and ignored, and I think it is very important for us to focus on all these, and we are really grateful to have our friends and colleagues from our allied professions to come and joining and explain to our pediatric neurologist colleagues that what are the basics, what we need to see for a cerebral palsy child for holistic aware management. And thanks, Vandana, for joining. Yeah, I hand it over to Raju and Diptanshu. The floor is all yours. Raju, you are mute. You are mute. You are still mute. No, Raju, there is hyperactivity. You become unmute, then you mute yourself again. Yeah.
So today we'll be discussing 7 panelists. So I'll change the schedule. So initially I'll be starting with ophthalmology. So I'll be asking questions related to cerebral palsy with visual problems. As Madam already introduced, so Dr. Snehal, regarding this, as you know, that eye is the most commonly affected comorbid condition in children with cerebral palsy. Most common is visual impairment because of hypoglycemia is the most common cause, and you are facing a lot of problem with, especially with the visual impaired children, and again causing refractive seizure, causing further visual impairment. And one more common complication is those children require commonly the vigabatrin, and how to manage these children is a complex problem. So today we'll be having Dr. Snehal discussing about various causes for visual impairment in children with cerebral palsy, and how to diagnose, how they clinically presents, and what is the role of OCT in the diagnosis, and what is the current role of visual rehabilitation, and any evidence is there for that, and how to screen for vigabatrin toxicity in children with cerebral palsy, and the children with West syndrome with vigabatrin therapy. So to Dr. Snehal.
Thanks a lot, sir, for this warm introduction. And thank you to the entire team for having all of us over for such an interesting session. So first of all, I'd like to take you to the first question that you asked. Sir, if you could go back to the previous slide, we'll have the questions there itself.
Yeah. Yes. Is it visible?
Yes, but not the questions yet. So I just take the
What
first.
are the way?
Yes. So you
Yeah.
had asked, I think, the causes of visual impairment in children with cerebral palsy. So I would like to divide this in two aspects. Number one would be a peripheral reason, and the number two would be a central. So if you look at the ocular causes of visual impairment in such children, most common would be the refractive errors. So hypermetropia and astigmatism being the most common. And another very important thing, which even as ophthalmologists, people may tend to neglect, would be accommodation issues. So they would have difficulties in near vision tasks. So I think that is the most important cause of visual impairment in children with cerebral palsy. Second would be strabismus or squint. And that itself can even lead to strabismic amblyopia. So that is the second cause. And obviously the third would be any fundus abnormalities. So that again, I'd like to divide into two parts. Number one would be optic atrophy, which can itself cause vision loss. And the second would be these children may be preterm and they may have sequelae of ROP itself. So these would be basically the ocular causes of visual impairment. And the second part of this would be the cerebral visual impairment. So these are the two main divisions of visual impairment in children with cerebral palsy. So whenever we talk about CVI in these children, they would have certain aspects of vision loss, which would not only mean defective visual acuity, it would also mean reduced visual fields, reduced contrast sensitivity, stereopsis, and even asymmetrical or absent optokinetic nystagmus, and alteration in saccades and pursuits, which would eventually affect their functional vision. So I hope that answers the question that has been raised here.
Snehal, Snehal, 1 second. Sorry. I actually forgot to introduce our expert, Dr. Lokesh Lingappa, who is our next president of Association of Eye Neurology, who would succeed me as the presidency, is there as an expert. Sorry, Lokesh, I forgot to introduce you. Lokesh,
absolutely, no problem. Yeah. Thank you.
Sorry.
Not an issue.
Sorry, Snehal. Yeah, Snehal, please continue. Yeah.
So I hope that answers the first question here, where you've asked about visual impairment in children with cerebral palsy. Now, how they present and how to assess. So they usually present to us with complaints that my child cannot see. Right. So, so if you can go to the next slide here. So how we as ophthalmologists would like to evaluate a child with CVI, a suspected CVI, is obviously number one, taking a history and a detailed ophthalmic evaluation where we would treat the treatable causes like refractive errors or strabismus, all those things which we can treat. We do that first. The second, of course, would be neuroimaging, because that would help us correlating the part of brain affected with the possible vision related issue. The third would be assessing the visual functions, like I mentioned, the acuity, the contrast, stereopsis, and all the others. And the last and very, very important is the functional vision assessment. What I mean by that is the amount of vision which the child has, how the child can use it meaningfully in his day-to-day activities. So that essentially would mean the functional vision assessment. These are the four most important things that we would do to evaluate a child with CVI. So I think hopefully that would answer the question. I have a couple of videos here, which I'll go through towards the end so that we can understand better. Very short, few second videos. So if you can go back to the questions again. So I think the question was a role of VEP in okay, how do you diagnose CVI and role of OCT? So I think I mentioned about diagnosis of
Yeah.
CVI. The role of OCT in diagnosis would be essentially just to know how much the macular ganglion cell layer is affected. So if there is a patient with optic atrophy, we'll be able to prognosticate, because the parents would eventually ask us, how will the child's future be? So the macular ganglion cell layer on OCT would probably just help us to prognosticate, nothing more than that per se in diagnosis. As far as VEP is concerned, we don't use it in our routine clinical practice for diagnosis of a case of CVI, because as I mentioned, we have a lot of other methods to eventually reach the diagnosis. But yes, it as we all know, it helps to assess the functional integrity of the visual pathway. So that's essentially how VEP would help, and especially in patients who are wherein the preferential looking tests are very difficult to do. In those situations, we can rely on a VEP. Now, if I talk about the role of visual rehabilitation, I'll take that question last, because I have 3 small short videos to show which will help understand better. I take the last question, how to detect vigabatrin toxicity in children with CP. So it is difficult to assess, no doubt, because these children would not cooperate for tests like visual fields. So what we can do is probably an ERG, an electroretinogram, which would help us to kind of diagnose. And that also obviously requires certain level of cooperation, but we do have handheld ERGs now, wherein the child can sit on the mother's lap and the ERG can be done. So that to an extent can help us. The OCT would just help us, like I mentioned earlier, about the retinal nerve fiber layer thinning and the macular ganglion cell layer thinning. Nothing much apart from that. So that's essentially how we'd go about detecting vigabatrin toxicity in children with CP. Now, coming to the role of visual rehabilitation, I think this is the most interesting question. And if we could run through those 3 videos, it'll be easier to explain. So if you can just go to those 3 videos.
Yes.
So if you can see here, as the child walks into the room, she's preferring to keep her head down. And when she looks up, she kind of, I think it's moving a bit slow, but she stumbles upon objects on the floor. So that essentially would happen because she has a lower visual field impairment. So how we would help such children is by telling the parents to just encourage them to look down and walk, so that they kind of are able to see, and they're not handicapped because of the inferior field effect that they have. If we can go to the second video. Yeah, so another thing which they often face, again, because of the inferior field effect and possibly the optic ataxia involving the lower limbs, would be difficulty in walking down the stairs. So for all these things, simple instruction to parents would again be giving support to the child while walking down the stairs, encouraging the child to look down and walk. These simple methods can help the child use his vision much better and function much better in the environment. And if you see the last video, so the child here, yeah. So if you see, there is an uneven ground here, and the child is finding it difficult to walk on that uneven surface because she has an inferior field effect, optic ataxia involving the lower limb, and very importantly, even impaired depth perception or stereopsis. So this is how she's not able to use her vision in a meaningful way. So simple modifications like assisting them while walking on uneven ground can really help them. Few more examples would be in children with hemianopia. If they're sitting in a classroom, the teacher can be instructed before, and the teacher can be in the viewing side of the child. In children having simultanagnosia, wherein they are getting confused with multiple things or crowding, the parents can simply be encouraged to declutter their home environment, use simple bed sheets at home, keep the child's things separately. So these small modifications can really help in terms of rehabilitating the child. So, Dr. Raju, I hope that answers the questions that have been put here.
Yeah, thank you. Madam, there are some few questions. Should I ask now only itself?
I think we should ask in the end because, so that everybody gets equal time. Otherwise, we'll go on adding it. Until unless if Dr. Snehal is going to stay on, then we can ask in the end if she's.
Sure, I'll stay on.
Yeah, thanks. That will make sense.
Thank
Then you have discussion in the end. Yeah.
So thank you for that. So next, Dr. Vandana Jain has joined, madam. So I'll be asking endocrinology.
Doctor, I can even answer them on the chat box if that's okay.
Yeah, okay. No, I can. So next, our topic will be on endocrinology in children with cerebral palsy. So as you know, endocrinology, the growth plays important role. So you're facing a lot of problem, especially related to growth issues, and also regarding the bone and bone density. And these children commonly on multiple anti-seizure medication, causing again more bone metabolic condition, causing frequent fractures, all those problems. So today I'll be inviting Dr. Vandana Jain to discuss about these endocrine problems. So today Madam will be discussing on how to monitor growth chart in these children with cerebral palsy, and is there any need for special growth charts, and how to monitor bone health and manage in children with cerebral palsy, and role of calcium and vitamin D3 supplements, and indication for bone density assessment, and usefulness of DEXA scan, and treatment with bypass donates. And next, last question, what are the pivotal issues in cerebral palsy children and how to manage? Over to Dr. Vandana, madam.
Good evening, everyone, and thank you, Dr. Raju, Dr. Shefali Gulati ma'am, for inviting me. So I think all of these questions are very, very important. So regarding growth, definitely we know that children with cerebral palsy, typically they would not grow like a neurotypical child, and their growth would be lower. So to compare them with the normal growth charts would not be appropriate, because we'll be possibly over-diagnosing undernutrition and maybe under-diagnosing obesity. The most important thing when we are looking at the growth of a child with cerebral palsy is the GMFCS score. So based on that score, if the compromise is less, if the child is mostly ambulatory and is able to move around, then they can actually grow almost equivalent to a normal child. And actually, when you look at, there are some growth charts which are developed for these children. So there is some problem with the slides. So basically, when we look at the charts, there are separate charts for each GMFCS grade. So grade 1, 2, 3, 4, 5, we have different charts for boys and girls for weight, height, BMI. So if we look at the GMFCS 5, I'm not able to look at my table. Just let me open it in my, just give me 1 minute. Yeah.
Lights are visible, I think, madam.
Okay, yeah. So somehow to me, they're not very clearly visible. So like, yeah,
Okay,
so for like GMFCS 5, if we look at the height for a 10-year-old boy, it is the 50th centile is 122 centimeters. Similarly, the weight for a 10-year-old boy, 50th centile is approximately 25 kgs. If we compare it with a neurotypical child, whether it is IAP charts or is it or if it is CDC or WHO charts, then typically this weight would be approximately 6 to 7 kilos lower, and the height would be as low as about 10 centimeters lower than a neurotypical child. If we see at 20 years, which would be roughly equivalent to the adult age, then also we see that the 50th centile for height is as low as 148 centimeters. This is for boys. And similarly for weight, it is as low as 37 kgs. So we can understand that this is what is expected, that if the child has GMFCS of 5, so non-ambulatory child, then the weight and height have to be compared to a child of that GMFCS score only. On the other hand, if we see, if I have plotted for 3 GMFCS score 3 and 1, again to show that basically if the compromise is less, if the child is ambulatory, then the growth is less compromised. And especially if we look at between 10 to 20 years, that is during the pubertal growth spurt, the puberty related growth is also more if the GMFCS score is lesser, if the classification is better. So the reason is multiple. Of course, there are the most important thing is nutrition related. But most of them have problem with maintaining good nutrition. And the other important thing would be related to the mechanical factors, because the growth of the bone, the linear growth is related to how much mechanical strain is there on the bone. So if the child is non-ambulatory, that growth is compromised. So definitely we should use specific growth charts. As far as I know, there are no such growth charts for Indian children, but I think it is perfectly okay if we use the charts which are available in like the ones I've quoted in Pediatrics 2011, and then we plot the child. The child should be following his or her own centile. If there is a deviation in the centile, then we have to be worried about under or over nutrition. So we can go to the next question, I think. So this is,
bone health.
yeah, bone health. So bone health is something which is very, very important. We occasionally see children with full-blown scurvy or with very gross rickets. We have previously seen children with even brown tumor due to long-standing vitamin D deficiency with secondary hyperparathyroidism leading to very exaggerated osteitis fibrosa cystica and presenting as brown tumor. Then very recently in our OPD, we saw a child who was 11 years old. He was non-ambulatory due to cerebral palsy. And in the last 6 months, the child had 4 fractures, both the upper limb and both the lower limb fractures he had sustained over the last 6 months alone. So, and when we evaluated the child, he was found to have a calcium of 5.9, 25 hydroxy D of less than 3 nanogram per ml, with a PTH which was more than 500, alkaline phosphatase which was more than 2000. So in non-ambulatory children with cerebral palsy, there are multiple risk factors for poor bone health. Again, a very important factor is being non-ambulatory per se. So weight bearing, mechanical strain, muscle mass, these are all the factors which improve bone health, bone mineral density accrual. We know that bone mineral density accrual occurs the most dynamically either during early childhood and then during the pubertal growth spurt. So because the growth is compromised, and then in many children, somehow the puberty may be compromised either by itself due to various reasons, due to poor nutrition. Sometimes the puberty is also delayed, or sometimes, unnecessary interference with the puberty just because the parents are not they don't understand the importance. They may go to a doctor and they may be put on GnRH analogs or something. So that may be another reason. Then of course, calcium intake, vitamin D intake is poor. Unless it is supplemented, it would be very difficult to meet the demands. We know that calcium requirement per se is also quite significant. For example, in less than 3 years, up to 700 mg, 3 to 10 years around 1000 mg, and then more than 10 during the adolescent growth spurt, around 1300 mg per day of calcium is required. And to have that, one must have a very significant, substantial amount of dairy intake. That is the only source. And then vitamin D, of course, either you supplement or you have enough sunlight exposure. So sunlight exposure per se would also be very, very limited in most of these children. And then anti-seizure medication could be another contributory factor for having a poor calcium and vitamin D status in these children. So what are the measures that can be taken? One is that, it's not required to screen everybody right from the very beginning with a DEXA or something like that. But you must ensure that, these preventive or conservative measures are followed, that we take care of their calcium and vitamin D, we take care of their overall nutrition so that growth is improved. And if growth improves, then of course the bone health will also improve. Weight bearing kind of exercise. In fact, there are some papers regarding use of a standing frame in children who are non-ambulatory to make them bear weight for some time. Children who are ambulatory, again, the ambulation should be encouraged. And if puberty is delayed, then puberty should be initiated with appropriate treatment. So if after supplementing calcium, vitamin D and all, if still there is a problem, like for example, if the child has fragility fracture, fragility fracture of a long bone. Basically, what is osteoporosis? In children, osteoporosis is defined as a bone mineral density which is below -2 Z-score for age and gender, using ideally ethnic specific charts, but if not available, then general charts. Along with that, along with the low BMD, the child has to have had significant significant fragility fractures of the long bones. So in children below 10 years, more than or equal to 2 fractures. Children below 19 years, more than or equal to 3 fractures. Or if there is a vertebral compression fracture. Vertebral compression fracture without significant trauma, even without any, looking at the BMD, you can diagnose that there is osteoporosis. So if there is osteoporosis which persists after taking care of calcium, vitamin D and other conservative measures, or if there are fragility fractures, then we should consider giving bisphosphonate therapy. So how do bisphosphonates work? Basically, they reduce the bone resorption, the bone resorption which is occurring at the endochondral side. So that is reduced, and that is how over time, as the bone resorption is reduced, but the bone secretion continues, so the bone mineral density improves. And typically the use of, you have oral agents like alendronate or risedronate, but these are typically very mild kind of, so they can be used in continuation phase. But typically you first have to begin with either pamidronate or zoledronate. So zoledronate is the one which is probably the easiest to use, because you have to give one injection every 3 to 6 months. So typically every 6 months is quite doable. So that can be done, but before giving bisphosphonate, you have to ensure that the calcium and vitamin D status are normal. Otherwise, you can precipitate a hypocalcemic seizure. So bisphosphonates can cause hypocalcemia. So that has to be kept in mind. So rest everything, I think, exposure to sunlight and all those things we need to take care of. So coming to the last question, which was related to puberty. So puberty, we know that many children with cerebral palsy may have either some structural deficits or sometimes hydrocephalus, which can precipitate early onset of puberty. Typically, it is not precocious. Precocious will be less than 8 in a girl or less than 9 in a boy, but many times it is early. So early is more common, but yes, because of poor nutrition, because of various other reasons, sometimes there may be delayed puberty as well. So many parents perceive that as soon as there is thilarchy, they would come and they would be worried that the child would start having menstruation, and how would we cope? So yes, this is an important concern, that how will you cope in a child with incontinence in whom bladder bowel itself is an issue and now menstruation. So, but then you have to basically explain to the parents very nicely that puberty is important for overall growth and development of the child, for bone health, for improving muscle mass. And in fact, this may sometimes improve their gross motor function if they have adequate pubertal growth. So puberty is something that should be welcomed rather than be scared of. So then you can guide them on how to manage menstruation. If still it is very difficult, or if it is truly very early and we feel that, okay, we need to do something about it, then if you use GnRH analogs, they should be used with caution and for a small time only. Let's say maybe for 1 to 2 years, or at the most, 2.5 years, but not beyond that. And when we use GnRH analogs, we know that they are going to compromise the BMD. So we take care of calcium, vitamin D supplementation if we use them. If menstruation is the only concern, then dipomedroxyprogesterone acetate injection can be given, which is a 3-monthly depot preparation of progesterone, which can be used because it will reduce the menstrual bleeding. Or another thing that can be done in adolescent girls is to put in an hormone releasing IUD like Mirena. So that will basically take care of the menstrual bleeding, and typically within 6 months or so, the menstrual bleeding reduces, and that can be kept in situ for as long as 5 years. So under GA, with the help of a gynae-obs person, this can be done. So this takes care of menstruation. If there is delayed puberty, then again, it should be taken care of. Puberty can be induced by giving estrogen in girls or by giving testosterone injection in boys.
Thank you, madam, for that wonderful answers. Okay. So next, I'll be going to ENT. So for the ENT, we are in discussion with Dr. Meghnad. So madam already introduced. So as you know, the ENT problem is a very common problem in children with cerebral palsy. That can be because of many reasons, maybe middle ear, or it can be because of cortex, or it may be because of cochlea. So today, sir will be discussing on various causes of hearing impairment in children with cerebral palsy, and what are the different modes of testing visual impairment, and how common and how to suspect middle ear pathology in these children, and indication for hearing aid and cochlear implant. Last one is how to manage rolling. Over to Dr. Meghna.
Thank you very much, Dr. Raju, and all the other members of the August meeting. The
Yes, sir.
commonest cause of, am I audible?
Yes, sir, you are audible.
Yeah. The commonest cause of hearing impairment in children with cerebral palsy is middle ear effusion, more than the serious or more difficult issues. This is a much simpler issue. The otitis media with effusion or middle ear infection is in around 20% of the children with cerebral palsy, because their swallowing is abnormal. See, if you look at the functioning of the middle ear requires influx of air through the eustachian tube, which is in the nasopharynx. And this eustachian tube opens whenever there is a good amount of swallowing. And that time, air enters the middle ear. In children with cerebral palsy, the swallowing movement, motor function is abnormal or underdeveloped. And because of that, there will be more chances of negative pressure in the middle ear, and thereby they have high risk of middle ear effusion. The studies say that anywhere ranging from 10 to 25% is the incidence of middle ear effusion in children with cerebral palsy, which unfortunately make the things worse. This can be diagnosed with an otoscopy and impedance audiometry. You will see a flat curve, or the gradient will be very high. It may not be a flat curve. It can be a very high gradient. Then also you have to suspect there is effusion in the middle ear, and this has to be treated by putting a grommet in the middle ear, we try to put a grommet which lasts for longer period than in the normal children. And the other causes of hearing loss are cochlear and neural type of hearing loss. Auditory neuropathy is also quite common in cerebral palsy patients. Means auditory neuropathy, central processing, the neural processing disorder. So in the cochlear type of hearing loss, the cochlear implant will definitely help. Many times hearing aid also helps. And if the hearing loss is between 35 decibels and 75 decibels, we will support them with a hearing aid. And in the children, when you are fitting a hearing aid, you must give a soft mold to fit the hearing aid properly. This is very important in children, especially with cerebral palsy. Many people put the hearing aid with like an adult, but that is not the right way. You must give a soft mold, especially in these patients. When the hearing loss is more than 75 decibels, and if it is the cochlear type of hearing loss, then you can do the cochlear implant. Regarding the indication for BERA, if OAE is normal, see, OAE normal means cochlear hair cells are functioning. They are generating the potentials. So first thing is, before OAE, we should do behavioral observation audiometry. And if that is abnormal, that is showing hearing loss, then we will do the, of course, OAE. If OAE is normal, means the cochlear functioning is there. That doesn't signify how is the nerve functioning. So still there is a possibility of hearing loss. So we have to do the BERA and auditory steady state response audiometry, also called as ASSR. And if OAE is normal and BERA is abnormal, means the pathology is probably in the nerve. And this can happen because of delay in the neuronal maturation. So in such a situation, even if the BERA is abnormal, such as hearing loss, we have to repeat the BERA at serial intervals of 1 to 2 months. And if there is some improvement in the hearing function, so we have to wait for the maturation, neuronal maturation. How common is the middle ear pathology in cerebral palsy cases? It is anywhere ranging between 10 to 25%. So when do we give the hearing aid? When the hearing loss is more than 30-35 decibels and less than 65 to 75 decibels. And not only that, with the hearing aid, you can do a cortical response audiometry and see how is the improvement in the hearing, and accordingly, you can decide whether to go with the hearing aid or not. And also you will understand how much of benefit is being provided by the hearing aid. So already we discussed the cochlear implant indications are when the hearing aid is not benefiting the patient, when the OAE is absent, when the defect or discontinuity is in the cochlea and not in the nerve. In that scenario, cochlear implant gives excellent result. But again, in auditory neuropathy spectrum disorders, when the problem is in the nerve, when the lesion is in the nerve, then also the only option is the cochlear implant, and it works in about 50 to 70% of the cases, unlike when the problem is in the cochlear hair cells. When there is outer hair cell dysfunction, cochlear implant, it probably gives nearly 100% chance of improving the hearing. But whereas when the outer hair cell function is normal, in that scenario, the cochlear implant results are little guarded. And coming to how to manage the drooling, and drooling, of course, this is a very big chapter and much complicated. So we divide drooling into two types, anterior and posterior drooling. Anterior drooling is because of the oromotor dyspraxia, and sometimes seen in autism cases also, because it's a because of the sensory issue. And the posterior drooling is also very important because that causes aspiration and recurrent pneumonitis and damage, lung damage, permanent lung damage. So if there is aspiration, an ENT surgeon should go ahead with the aggressive management of the drooling as early as possible to preserve the lungs. But if there is no aspiration, the surgery should be delayed till the age of 6 years. But when you think of drooling, we have to differentiate between the hypersalivation and the actual drooling. Whenever there is a finger chewing, dental decay, and gastroesophageal reflex, we have to think of hypersalivation. And another issue is the open mouth posture. This could be because of the adenoids. In one of the study, I think done in Birmingham, and 12% of the children who came to their clinic with drooling got the benefit by simple adenoidectomy. So which is a very important factor. Always look for the mouth breathing, open mouth posture, look for the adenoids in X-ray of the nasopharynx. And if the adenoids are more than grade 3, more than occupying 50% of the space, and you should go ahead with the adenoidectomy before thinking of other serious measures. And another reason for the drooling is the trunk and head postural control. If that is not present in the kid, the drooling treatment will not be successful and should not be attempted. We should correct the posture by, I think that is the job of the orthopedic people. They have to do something on the wheelchair and manage it. Before doing any such measure things, you have to do the face functional endoscopic evaluation of the swallowing. And we do a test in quotient, DQ. We ask the parents to wipe the mouth every 15 seconds for 5 minutes and count the number of new saliva secretions drooling. This has to be done at rest and at the playtime also. Both are equally should be done. They're important. And as far as the management is concerned, I think transdermal patch of hyoscine hydrobromide, you can use it, but it has to be titrated according to the body weight. And you can give it once in 3 days. Probably that's a good support to these patients. The other option is glycopyrronium and trihexyphenidyl hydrochloride. Of course, neurologists do give Botox. Usually we recommend 4 units per kg body weight, and 66%, 2/3 in the submandibular salivary glands and 1/3 in the parotid glands. And one important cause for this problem is reflex. Gastroesophageal reflex is also one of the cause for the drooling. And if it is present, I think one should consider fundoplication. And if all these measures fail, probably submandibular duct transfer to the inferior pole of the tonsil. If I'm doing the surgery, at the same time, I would excise the sublingual salivary glands also in the same sitting, because if you don't do the sublingual salivary gland excision, these patients are likely to develop a ranula, and which is a much troublesome to deal with. I think probably I covered all the questions, and now it's open for any questions, please.
Thank you, sir. Thanks for your valuable comments and important messages also that indicates the importance of ENT consultation, those children, especially those with severe cerebral palsy cases. Thank you, sir. So,
Dr. Meghna, I'd like to add one thing. Although we have a speech and language pathologist who would be possibly speaking on the oromotor therapy aspect, but from your perspective, would you like to add anything in that context? You are on mute. So you are on mute.
Guidance from the swallowing therapist is very important. That itself will help many patients.
Okay, thank you. Dr. Raju, are we moving to Viniti ji right now?
Yeah, you'll be. So next we'll be discussing on related to problem related to speech and language. So as you know that the speech and language is a very common problem in these children, especially communication, both can be in a receptive and expressive also. So today we'll be discussing related to this one's.
Yes, please. Yes.
Yeah. So we'll be discussing how to manage oromotor dysfunction as you were discussing in these children with cerebral palsy, especially those with a lot of feeding problem. And one specific subtype cerebral palsy, like where penicillin subtype cerebral palsy, these children predominantly comes with expressive speech problem, and cognitively they'll be relatively okay, but the speech expression is a predominant problem with lot of drooling and tongue abnormalities. So how to manage these children? And especially those children with severe cerebral palsy with epileptic spasm, they will be having a lot of artistic features also. So how will you go with these children with management of speech and language?
Okay, thank you so much for inviting me. Thank you, Dr. Gulati, for having me here today. Yeah, as you all have heard that speech and language is very core and important.
Viniti, thanks for sharing your video. Na,
Yeah.
your upper part is getting cut. Thoda sa screen ko theek karte. Yeah.
Okay.
Sorry. Yeah. Thanks.
Are you able to hear me? Am I audible?
Yes, you are audible.
Yeah.
You're able to see me as well?
Yeah.
What I would recommend is that if we can, you're using a cell phone, looks like. So you can shift the time. You can shift the time so your face is visible. Because right now your face is getting cut up to your toes.
Right now it's fine.
Can you hear me now? Can you see me?
Fine. Yes,
Yeah, this is good.
Absolutely.
I think the video is not sure why.
Madam, please continue.
Okay, good evening, everybody. And thank you for having me here today, especially Dr. Gulati. Thank you so much. Okay, I would like to touch on a very important topic here about how to manage individuals with cerebral palsy from a speech and language perspective. So this perspective is definitely something that concerns all of us, since communication and swallowing are daily life activities, right? So thinking about cerebral palsy, as we've heard quite a bit now, that it has multiple issues. We are dealing with a multifaceted problem. And we all have to kind of contribute a part to it to be able to have a good care and support plan to manage these individuals, right? So a care and support plan for these individuals would involve allied health professionals like us as well, who would work and intervene with them and do a lot of drill work in terms of repetition and revision to build the strength, the muscle strength, and appropriate range of movement to be able to, manage their feeding, saliva control, as well as speech functions. So looking at the first question, how to manage oral motor dysfunction in children with cerebral palsy. Now, we know that motor involvement is predominantly seen in individuals with cerebral palsy. And this is something that concerns all of us in terms of how to build muscle strength in various groups. So the first and foremost thing that as a speech therapist, as an intervention, we focus on is the respiration. And we also look at building phonation, which is consistent airflow for speech. Appropriate resonation as well as articulation. When we're looking at articulation, we are focused on building jaw stability, symmetry, and because what we notice is a lot of jaw jerk reflexes in these individuals. So we need to build appropriate jaw stability and strength in these individuals, and also build grading. We could use bite blocks to build that. And there are a lot of talk tools available to build these kind of, to build jaw stability. The next area that we look at is in terms of lips, to build up lip control, to build, to be able to open and close lips, to build lip seal, which is an important aspect when we are looking at even saliva control within the mouth. So, and of course, also important for speech production, target speech production at some point. So we are looking at building up lip closure. We are looking at building protrusion and rounding of lips, as well as retraction. So lips are something that we focus. A lot of oral training involves lip training to build strength, and also for as a prerequisite for speech production at a later point. The next point is the tongue. The tongue is very important, both in terms of propelling food within the mouth, as well as saliva control and speech production. So tongue, we also want to really build on retraction, lateralization. We want to make sure that there's enough strength and range of movement, and as well as the elevation. So we're looking at the tongue tip, and specific to the tongue tip, we're looking at elevation of the tongue tip. So this is definitely an important aspect of the oral motor training when we are looking at the dysfunction in cerebral palsy. And there are a lot of tools nowadays that we as speech and language pathologists use to build up a hierarchy of lip strength, as well as tongue control and jaw stability. Like I said, bite blocks are one of them. The other type of tools we use is straw hierarchies. We use different type of straws to build up grading, and we when we're looking at sucking function, we are also looking at horns and blowing kits, where we look at different type of horns to build enough ability to have consistent airflow. And these are the tools that we use to build up the oral motor and the speech mechanism, and as a prerequisite for further speech production. So these are some of the things. On top of that, we also use tongue depressors. So there are a variety of tools nowadays that are used by speech and language therapists to build up oral motor, to work on oral motor dysfunction. And this is part of our oral motor training. That answers the first question. The next question, how to manage children with perisylvian subtype of CP, especially when we are looking at the localization being cerebral and cortical. What we are looking at is multiple difficulties with not just drooling and speech, but also cognition. So there are lots of areas that are involved when we are looking at this specific perisylvian subtype of CP. Conventional speech therapy, to be honest, is controversial. We need to really start early in these individuals when we look at management. The early, the better. And we may also, when we're looking at specific speech concerns, we are looking at building a good AAC device for them, or different type of aids we could use or tools to help augment or their speech. Since cognition is involved, a lot of them also have learning issues, or they have specific language concerns which limit their ability to understand. So what we are really looking at is building a good understanding, building functional communication with them through AACs. We could use pictures or digital devices or tech aids to, again, varying from child to child in terms of what their motor abilities are and how they understand people around them. So we need to really, since each individual is different, we need to kind of vary this. And as a speech therapist, our recommendation would vary from across different individuals. Relating to drooling, of course, what we are looking at is, again, we would start working with a lot of building oral control. We would again go back to a lot of exercises that we do to build oral motor functions and get the individual ready for further speech production. So when we have a case of drooling, we also are looking at their feeding and their swallowing as well at the same time. So these are the things that are quite significantly involved in perisylvian subtype of CP. And there is a significant speech and communication concern in them. So we would definitely, in the management, have them start as early as we can. The earlier, the better. And we would also recommend a good AAC to begin with, so that they could still learn to communicate and understand people around them, which is their caregivers, their parents, and people from their immediate family. So this is something that we would do with perisylvian subtype of CP. The next question, how to manage these children with autistic features with CP? Now, there is comorbidity with CP being involved with autism, and there are a significant number of individuals where we do see a lot of issues with not just their speech, language and communication, but also their social interaction, their reciprocal social interaction with others around them. So when we're looking at autism being implied in individuals with cerebral palsy, we are also looking at we may have poor attention span. We may also have specific motor organizational issues with such individuals. As a speech therapist who is also working with individuals with autism, we would use specific approaches to manage language in autism or communication in autism in these individuals. We would also look at picture exchange communication system as one of their type of an AAC, or we could also look at structured teaching, which is a teach-based approach that we use for individuals with autism to give them more structure, to give them, to tell them exactly how much and what they're going to do with us and when it would finish. So we are trying to include their, make more sense of what we are doing with them, have them really engage with us more, because individuals with autism, socially being face-to-face with them could also be a concern, where they may lack eye contact, or they may not be able to kind of copy exactly what we're expecting them to do. And any repetition or any exercises would then have some concern at times. So with these individuals, we need to make sure that we have specific autism-friendly approaches in place for them. We manage their attention. We manage their, give them more organized way of doing various activities, even if it's simple oral motor exercises with them, make it more visual for them so they can respond, and that being their strength, they could respond to it a lot more better. So these are the things that we would involve if a child with, or an individual with cerebral palsy may have comorbidity and may have some features of autism. Again, it's a spectrum, so individuals with having autistic-like features may also vary. So we have to evaluate, we have to detect what level they are at. And again, going back to the severity, again, if you have a mild concern, prognosis, of course, is a lot more better in these situations. And if we have a more severe involvement, then prognosis, again, could vary in those individuals. And we also see, in going back to the perisylvian subtype, there may be regression at times. So we need to really monitor these individuals, be very consistent in our approach when we are training them or working with them. And we do at every point involve parents and caregivers so that they are able to kind of reciprocate whatever we are doing in a session with them or in an intervention session with them, and they could practice and do at home and across context. So an ideal therapy would involve working with the child as well as the parents. So it's very important that parents and caregivers understand what we do. Only then would they be able to kind of replicate what we have said across different contexts. So what I would like to end with is that it takes a village to really support these individuals. And as we have seen, there's variety of disciplines who are really involved with any individual with cerebral palsy. It's such a multifaceted concern. And so allied health like us would definitely step in at some point to kind of support not just saliva control or drooling, but also their speech, their language, their social interaction and communication concerns. So we're looking at a range of these concerns and skills when we are dealing with individuals with cerebral palsy. That's all from me. Thank you.
Thank you.
Thank you, Dr.
Vinitiji, one thing I'd like to add here, which is, I think, very contextual. In case of children with cerebral palsy, often we see intellectual disability as well as autistic features. So basically, there's a cognitive component involved. And when we talk about speech, essentially, in many situations, we miss out the prerequisites of speech. You've already touched on upon very pertinent issues relating to autistic children. But I think even when there's a cognitive delay, this is an area we often ignore. And unless that portion is addressed, I think just working on the oromotor part will not work. So I think that part was something I needed to add. And it was a great thing that you focused on the involvement of the parents, which is very crucial. And not only on this speech aspect, on all the aspects of the dealing of cerebral palsy. Thank you.
Yeah. Thank you so much. Thank you.
Rajuji, next.
So next we'll be talking on nutrition in children with cerebral palsy. So as you know, nutrition has already Dr. Vandana Jain has spoken, but regarding the dietary management in children with cerebral palsy, so now Dr. Roshan will be talking how to assess nutrition status in these children clinically, and any laboratory investigation are required, and diet advice in children with these children with cerebral palsy, especially with oromotor dysfunction, gastroesophageal reflux disease, and constipation. and especially how to prevent any specific advice you will advise for micronutrition deficiency in these children. Over to Dr. Roshan.
Thank you, Dr. Raju. So this was like a power-packed session with a lot of information flowing from all directions. Coming to nutrition, nutritional assessment, as we all agree, is very, very important. But in patients with CPA, it is the most difficult thing to do. Like we have already heard, growth charts can be used specifically for children with CP. But it is very difficult to get the correct weight of the child and even more difficult to get the height. So when we are talking about anthropometry, to plot these growth charts, we have to realize that weight for height really doesn't work because the height assessment is very, very difficult to do in a clinical setup. Percent ideal body weight also doesn't work really well. BMIs are not reliable because our measurements are very compromised. So skin fold thickness is something that can be used, but it may not be as reliable because we know that in children with cerebral palsy, the fat deposits are at a unique distribution. So there is more of the abdominal or the central fat than all over the body. So we have to be wary about what scale we are using. DEXA is something which is recommended, but I don't think in our Indian clinical scenarios, it is the most easily available or the most recommended, but it is something you can really use if required. Laboratory analysis, things like albumin and pre-albumin would give you an idea about the nutritional status when it comes to the protein, and it can be reliable. So what I would emphasize more from a nutritionist point of view is taking a detailed nutrition and feeding history. So when you're taking the history for nutrition, you have to emphasize on the gastrointestinal problems, if any, faced by the child. This could be gastroesophageal reflux or chronic constipation, because this is what is going to affect the child's food intake and its assimilation, digestion, and absorption. Next, dependence on feeding is one question I usually like to ask, because self-feeding is very difficult for most of our children, if not all, and they can be partially or wholly dependent on caregivers of feeding. And as we all realize that it is very difficult to take care of the child, so feeding may not always happen at the right time. There may not be enough patience on the part of the caretakers to give enough energy or resources for the feeding process. There could be feeding dysfunction, and that the child may be requiring foods which are pureed or mashed or blenderized. And we need to take that into consideration, because that way we are also compromising on the content that can go in those pureed feeds because of it being liquidy in nature. Feeding skills are compromised. So assessing the periodically to identify nutritional risk, we need to check if there is tongue thrust, there is drooling, there is dribbling causing fluid losses. There is lack of hand-mouth coordination affecting the food intake. Poor lip seal, as we discussed earlier, is also one of the risk factors in poor nutrition. Inability to communicate hunger, something as basic as that, can also compromise on the child's feeding and the nutritional status. The prolonged feeding time and dysphagia further adds to the feeding problems and the nutritional access to the food for the child. We should also consider other medical conditions and respiratory illnesses and the frequency, because that further tells you the status of the child. As we all know and agree that nutritional deficiency will give rise to further respiratory infections besides the aspirations and microaspiration. So this should also be considered, and a child with frequent infections is also can be considered as malnourished. So I think that answers the question for assessing the nutritional status. Coming to diet advice in children with oromotor dysfunction. For oromotor dysfunction, we have to realize that the first thing we need to check is the child's posture while the child is eating. The physiotherapist would be helping a lot in this matter. And so having a conversation or communication with the physiotherapist is very important to have the child in a correct posture when he is feeding, because it is very difficult to feed a child who is having a neck completely tilted on one side or who is in a supine position and cannot be made to sit in a sippy chair, and then it is very difficult to swallow the food that is being fed to the child, and lot is lost while the feeding process. You have to also, I would like to urge the physicians to think of advising a tube feeding or a peg feeding at the earliest possible rather than later. We see a lot of these children get assessed and recommended a tube feeding quite late when the malnutrition is completely set in as a last resort, when spasticity is maximum. So it can be considered as a first line of treatment for nutritional malnutrition, so that we can ensure that enough food goes into the child. Besides that, coming to the consistency of the feeds, as I was saying earlier also, we need to be open to modifying the consistency of the feed as per the child's requirement. A lot of parents feel that the child will be getting used to the thick or the normal consistency of food, and if they don't feed that, the child will lose the touch and will lose the habit of eating solids. But this is not true. If a child is comfortable eating mashed food, he should be recommended mashed food. If he's comfortable eating blenderized food, that is what should be recommended, because the quantity that the child will be able to eat depends on his capacity or ability to eat. Coming to GERD, I think the gastroenterologist would be talking a little bit more on this, but from a nutrition point of view, we recommend that thickened feeds be added to the child's diet to avoid or to reduce the GERD, the gastroesophageal reflux. And the thickening can be made, as I was describing earlier, by blenderizing the feeds, by adding certain amylase-rich flours, which will help to give density to the feed, keep the feed smooth, and also concentrate the nutrients. So giving liquid feeds is always going to worsen the GERD, but solid, thickened, mashed foods are a good option for reducing the reflux. Children with constipation, and I would like to answer this question with the next one, of how to get dietary micronutrient deficiencies can be dealt with. So the answer for both is to have a balanced diet. So in your day-to-day practice, it is very easy to inform the parents about getting adequate nutrients, including fiber and fluids, which will help with constipation, by following the principle of the balanced diet, that is using the principle of 5 food groups, where you insist that the parents include whole grain cereals, whole pulses rather than split dals or polished grains, using lot of vegetables and fruits as they provide with soluble fiber, and including fluid or water as one of the main nutrients, having a diet which does not have any kind of processed food. We see that the child's day will start with a cup of tea and 2 or 4 or 6 or 8 Mary biscuits or glucose biscuits dipped into it, just because it is convenient and it is easy to feed the child. So the parents need to be given options of soft, easily feedable foods. And to avoid micronutrient deficiencies, we have to tell them to give all the different foods in adequate quantities. We see that most of the feeds will be watery, and hence there will be no fiber in it. There will be not much of vegetables. So simple thing like telling the parents to include sieves or the strainers, which are little bigger. The soup strainers will help to get the pulp from the blenderized or the mashed food, and it is thicker. It is also having more fiber in it. Specifically related to constipation, we have to insist that soluble fiber in the form of oats or in the form of fruits and vegetables should be part of the day's diet. Also, other fiber in the form of whole grain cereals and non-polished pulses should be part of the child's diet. And not to forget the use of fluids, because with all the feeding difficulties, the fluid intake of these patients or these children is almost negligible. So fluids can be added to the feeds per se, so that it can be included easily in the diet. So that is about the nutritional things that tips I can give for improvement of the nutritional condition of the children with CP. We can take questions at the end if there are any.
Roshanji, I think you have excellently covered the entire thing. Would you like to add something about how the tube feeds in particular should be enhanced in these children?
Yeah, so without a guidance from the nutritionist or a dietitian, patients who come, or we observe in patients, parents don't know what to make for the tube feeds. So all they will give you is dal pani, chawal ka pani. So it is all watery gruels because they are worried that the tube will get blocked if you give anything much thicker. So what I advise my patients is to use the home cooked food, which is prepared for the whole family. Pick up one part from all the food groups and blenderize it. For example, a blenderized kitchen feed which has something like a rice or a roti or a bhakri in small portion, mixed with either a dal or curds or egg or chicken or milk, and addition of either a fruit or a cooked vegetable will give you all the basic food groups. And you blenderize the whole thing, add sugar if required, depending on the child's requirement, and oil to the feed. And this should be fed through the tube. So you can prepare n number of different feeds from in the blenderized form, which are later on strained with a soup strainer and given through the tube. Examples are milkshakes using fruits or dry fruits along with milk. It could be, I normally do not advise parents to use only soups because I feel it is a waste of one of the important feeds of the day, and suggest that the vegetable should be added to some cereal-based preparation. It can be something like a khichdi, which has lots of vegetables and dals in it. Also something like a porridge or a kheer made with different kinds of cereals and a combination of milk and some sugar, jaggery, some nuts powder added to it. So you can enhance the nutritional content of the tube feeds by adding different food items, blenderizing it thoroughly, and then straining it before adding into the tube. Not to forget addition of oil to increase the calorie content. I hope that answers your question, Dr. Dipanshu.
Sure. Thanks a lot. Let's move on to the next speaker.
Next, going to pulmonology. As you know that these children, cerebral palsy children, frequently admitted for recurrent pneumonia because of aspiration and a lot of in maintaining respiration and also a lot of sleep issues. So now we'll be talking about related to problem related to pulmonology. So the points to be covered in this is how to prevent aspiration pneumonia in these children and how to treat recurrent pneumonias, and what are the indication for sleep studies and indication for home oxygen and ventilatory support. Dr. Sanjukta will be taking care of these questions.
Oh, thank you very much for inviting me to be part of this panel. And as respiratory complications are one of the commonest cause of admissions in hospital for children of cerebral palsy, and one of the commonest cause of mortality and morbidity in children of cerebral palsy. So there is a lot to cover, but obviously the time will not permit that. I will just take the first two questions together, and that what are the risk factors and how to prevent. So basically, what I would like to say is that we have my previous speakers have already made it easier for me in a way to address the problems. So the main thing is how to prevent aspiration pneumonia and how to treat recurrent pneumonia. If I can take those two questions together, the risk of aspiration pneumonia is, first we have to identify the risk factors. Only if we identify the risk factors, then we know that what we need to do. So a young person with CP with these risk factors, like if we classify on the GMFCS scale, the gross motor function classification system, and if they're on level 5, which is the worst, where they're confined to the wheelchair and needing support for most daily activities of living, then like it or not, they will have a lot of aspiration and they're at high risk. So they have difficulty controlling their head and body posture in most positions. And the second risk factor would be at least one hospital admission for respiratory illness in the year preceding the survey. Then oropharyngeal dysphagia, which has been dealt with beautifully in the previous by the previous speakers, recurrent or ongoing seizures, frequent symptoms, having a daily cough or weekly wheeze or a gurgly chest, gastroesophageal reflux disease, which has again been dealt with, at least 2 courses of antibiotic for chest infections in the past year, mealtime respiratory symptoms, like when they have a gurgly voice or wheezing or coughing or sneezing or choking, and snoring every night. So these are some of the risk factors that show that this child is at high risk of having aspiration pneumonia. And when we are, because aspiration not only happens due to GERD or happens due to the entry of food, the lung itself is weak and the lung cannot deal with the aspirated material. Also, the aspirated material technically should have some bacteria in it. So what are we to do when these children of CP we consider them to be at high risk of respiratory illness? So considering that risk, we should also apply 2 tools, which I'm sure my speech and language therapy colleagues will be aware of: the DOS scale and the EDAC scale. The DOS scale is the dysphagia outcome and severity scale, and the EDAC scale is the eating and drinking ability classification system. These 2 scales are very important, and as we do multidisciplinary care, as a pulmonologist, I would expect my speech and language therapist to guide me about who are doing badly on these scales. So when they are really doing badly, when they're in levels 3, 4, and 5, that means the person is able to take nutrition by mouth, but requires thickened fluids or thickened or pureed food. And level 6 and 7 means a person is able to eat a normal diet by mouth. So important of thickening is very important. On the EDAC scale also, the level 5 is unable to eat or drink safely. So that's where we use tube feeding. So as my previous speaker has said, the tube feeding should be instituted earlier than later. I wouldn't agree though that it is the first option, because it cannot be the first option. Where we have tube feeding or peg feeding, there is multiple problems for a family and in a country like ours. But if we apply the EDAC scale and the child is on the level 5, then obviously peg feeding is the only option. So we have to identify and prevent aspiration, and for that we also can apply video fluoroscopy. But many of the children also have silent aspiration without any outward sign, without any choking or coughing. So we need to be on our guard and have a regular review of these children. But video fluoroscopy or fiber optic endoscopy, either of these methods can be applied if we are in doubt. So uncontrolled seizures, dysphagia, reflux, and drooling of saliva, these are the highest 4 risk factors. And as my previous speakers have also dealt with how to deal with drooling, how to deal with reflux, our gastroenterology colleague will talk about that. But thickening of feet is very important. The help of a speech and language therapist is very important. And when we are suspecting that aspiration is going on, then the feeding and mealtime intervention and assessment by an individual trained in this, and teaching the mother to feed thickened feeds is not something very easy or to be taken lightly. So they should be given all help from the dietitian and from the speech therapist point of view to use thickened feeds. Obviously, uncontrolled seizures, and we need our neurologist colleagues. Reflux, we need our gastro colleagues. And for drooling, we can also deal with glycopyrrolate and with other measures. So physiotherapists also should prescribe techniques to maintain clear airways. Clinicians should identify early aspirations. And we have to realize that these children also have common childhood problems like adenoidal hypertrophy or asthma. So these are the things that also should be dealt with at a very early stage. So if a child is having asthmatic problems or adenoidal hypertrophy, we should identify that. And that's why snoring is one of the risk factors. So if a young child with CP has a history of apnea or snoring, or they have large tonsils and adenoids, removal can also very much aid in their swallowing. So, so physiotherapists, physical activity, optimizing, ambulating them, maintaining good nutritional support is important. And I would like to refer all the attendees here in today's meeting to refer to the consensus statement, which has been published by Gibson et al. In the Development Medicine and Child Neurology in August 2020, which has excellent guidelines. And this also recommends that spinal deformities should be corrected. And spinal deformities being corrected also prevents better motor ability and better swallowing ability as well. So the next we go to how to, how do we reduce pneumonias? A child in a house where, a child with CP, they should be protected from tobacco smoke, all kinds of smoke. And this is very important aspect of preventing infections and respiratory infections per se. Vaccinations against influenza, vaccinations against pneumonia, using the pneumococcal vaccines are extremely important. And it has been recommended that the entire family be vaccinated as well. Managing of asthma optimally is also very, very important. And ongoing surveillance for risk of respiratory illnesses should continue. So we need multidisciplinary teams, and the recommendation is a hospital admission for respiratory illness in the past 12 months, general motor functional level of level 5 and EDAX level of 3 to 5 for children over 3 years, or DOS for children under 3 years, should be red flag signs, and a respiratory physician should be involved in regular management. So we should also consider things like things that we have mentioned: oropharyngeal muscle training, prophylactic antibiotics. There is no recommendations per se, but one study has suggested that tobramycin, if given in intermittent dosing, actually that has crept into the recommendation. So I have used tobramycin in a few of my patients with good results. The dose is nebulized tobramycin for 28 days in BD dosage, 500 milligrams twice a day for 28 days at a stretch, then 28 days gap, and then you repeat the tobramycin again, and this continues. And it has been shown that this can reduce hospitalizations by almost half. So obviously, this is something that I think we can consider as a part of treatment and prevention of respiratory infections. And coming to the next questions, indications for sleep studies. I think the indication of sleep study will be the same, considering the motor functional scale and the DOS and the EDAX scale. So any child who has snoring, any child who has episodes of recurrent respiratory infections and hospital admissions should have a sleep study done. And if hypoxia is proved beyond doubt, or if there's adenotonsillar hypertrophy or obstructive events, then the adenoids and the tonsils need to be removed. And ENT intervention here is very important. Polysomnography is obviously, we do that to find out which child needs intervention. And nighttime CPAP or BiPAP will really help. Now, how do we know what are the red flag signs we should tell the parents? We should tell the parents about excessive daytime somnolence, changes in behavior of the child, pain or discomfort that the child has during nighttime and interrupting his nighttime sleep, or seizures during the night. These are all indications for doing sleep studies, and this is something that should not be delayed and should be done earlier rather than later, so we can intervene early. So upper airway problems are dealt with, and CPAP or non-invasive ventilation is advised for nighttime use as necessary. And indications and management of home oxygen and ventilator support, obviously the answer is in a child with again, the general motor functional scale and the EDAX and DOS comes in when making this difficult decision whether or not we need to give home oxygen. Obviously, a child with recurrent respiratory infections, recurrent hospitalizations, and evidence of hypoxia, they actually, in cerebral palsy cases, they actually benefit more from non-invasive ventilation and CPAP or BiPAP, whichever is feasible for them, because we have to do a trial, and rather than continued home oxygenation. Because if we are in a situation where continued home oxygenation is required, then we obviously have not done enough for the child in the first case. We have not identified the risk factors well enough. We haven't managed to prevent respiratory infections, and this is already too far gone. So basically, my answer to the last question would be that the indication should not be reached in the first place. We should be managing respiratory problems in such a way that we preempt them, that we understand the risk factors, we apply the motor functional scales, we apply the EDAX and the DOS scales by our speech therapist colleagues, so that we know when to start or change to tube feeding. We know what are the risk factors for recurrent infections, and we do the vaccinations, not only for the child, but for the entire family. We prevent exposure to smoke. We prevent hospital admissions. We treat asthma. We treat adenotonsillar hypertrophy. And obviously, with the help of our gastro colleagues and our ENT colleagues, we deal with adenoids and reflux. So the last also, but not the least, is where there is scoliosis, problems with neck holding or kyphoscoliosis. Consideration of a spine surgery may help in positioning and preventing respiratory illnesses, because obviously, if the spine is compromised, so is the lungs. So, so basically, we have to deal with all respiratory problems in a holistic way. I would request everyone, especially the any juniors who have logged in, to refer to the consensus guidelines, and also to consider cerebral palsy not only a neurological illness, because the morbidity is maximum from respiratory point of view. I will end my talk there. If there are any questions, I can take that.
Thanks, Dr. Nde, for the excellent deliberation. Let me apologize to the participants for the delay. We are taking a bit more of time, but I think it's worth it. We'll move on to the last speaker for today, Dr. Raj.
Yes. So everybody is waiting for gastroenterology. So maybe some overlap of GERD. So I'll be going directly to PEG tube insertion. So Dr. Nagendra will be talking about GIT problem in children with cerebral palsy. As you know, most of our multidisciplinary team commenting about the involvement of gastroenterologists in cerebral palsy children. So I'll be asking Dr. Nagendra regarding PEG tube insertion. What are the indications for tube insertion, and what are these complications, how to monitor, and approximate cost for this instrument, and what are the advantages over gastration feeding? Over to Dr. Nagendra.
Well, at outset, I would like to thank the August gathering here and the panelists, and thank Dr. Raju for providing me this opportunity. I mean, I think we always talk about gut-brain axis. So gut is very much involved in brain disorders. So I think I call gut as a second brain. So as you know, like previous speakers were also commenting about GERD and then risk of aspiration due to GERD and all. So anyway, because lack of time, will directly go into the PEG tube. So PEG stands for percutaneous endoscopic gastrostomy. Can I share my screen? I have some presentations.
Sure. Raju, withdraw or stop sharing, Raju. Raju, stop sharing your screen, and Mansi, please allow Dr. Nagendra to share.
I think this is under control.
Yeah. Can you see my screen?
No, not yet.
Not.
Yeah.
You just put your full screen on, but you have not shared the screen yet in Zoom.
Okay, I think okay. Can you see my screen now?
Yes, we can. You can
yeah,
make
now.
full screen.
Okay.
Yeah.
So basically objectives of PEG tube feeding, like previous speakers were speaking about when to consider PEG tube feeding based on ICARD score, based on regurgitation. So simple words, whenever you think that nasogastric tube or tube feeding is indicated for a long time, because it's not optional to keep nasogastric tube for a long time because of the complications over a nasal septum, or even tube itself in the pharynx can irritate the child, that can itself cause reflux increase in GERD, and also tube in the gastroesophageal junction again causes a problem with the reflux. So always PEG tube should be considered when you think there is a nutritional deficiency and long-standing feeding is indicated. And when it comes to the indications, so most of the, neuromuscular disorders sometimes need a PEG tube insertion. Most common being cerebral palsy, which we are discussing today. Apart from them, there are some metabolic storage disorders, neuroregression and trauma, swallowing difficulties, oropharyngeal incoordination, recurrent aspiration. So all these conditions, PEG tube is required. And there are some craniofacial abnormalities, oral malignancies, and infections. All these conditions do require PEG tube insertion. And so there are basically two techniques. This is a pull technique. This is how it looks after placing the PEG tube. And endoscopic. Pardon? Yeah. So most common indications are like what I have discussed previously. And when it comes to placement of PEG tube insertion, there are two techniques. One is pull technique and one is push technique. Pull technique, the advantages, or it is commonly used, the complications are less, and you get a varied size of tubes starting from 16 or 14 French to almost 24 French. So by this you can achieve bigger the tube, you can achieve bigger the feed size. And our dietitian was suggesting about churning the diet and giving that. So again, bigger tube will allow you to advise thicker tubes, which also further prevents GERD. And then but cosmetically there is a tube which is coming out, maybe a 1 feet or half feet of tube which is coming out of the tummy. And sometimes in the children with cerebral palsy, it may be difficult to often maintain. And so in other form of PEG tube is what we call it as Mickey button, where it is a very short button which will be in the place. And generally we can place it by a push technique, which is again newly developed. Equipment is bit costlier than pull technique. And then second is we may place the PEG tube by pull technique for couple of months, maybe 4 to 6 months. And then you can take out the tube and put this Mickey button. So Mickey button basically, I'll just show what is Mickey button. Okay, I don't have that endoscopic image. Placement procedure. Yeah, I don't have that picture. Basically, it is a very small button which stays in the stomach, and it is, you can easily put the shirt over it, and it is not visible at all. And you can put the tube as an attachment and feed through it whenever required. The main problem with Mickey button is the sizes are not much, and even though there are sizes from 14 French to 24, the port size is small. But the main advantage is cosmetic and functional liberty, which is their child can be taken out. There is no tube visible, So that is the advantage of Mickey button. So both these are available. When it comes to cost, so average cost for the PEG tube is around 6,000 to 7,000. There are various companies which are manufacturing that. For an example, Cook or Boston Scientific do that. And placement of Mickey tube, basically endoscopy and post-procedural stay in the hospital, maybe around 5 to 7 days. All depends on the setup where you are putting the tube. And if it is a public sector, the cost will be quite less. And when you want to replace it with Mickey button, so you can, Mickey button would cost around 5 to 6,000, and you can do it in the OPD basis. Sometimes pulling out the PEG tube may be difficult. Sometimes it may require redo endoscopy, but sometimes you can pull it off easily and then place the Mickey button. Once you place the Mickey button, you can replace it how many times you want in the OPD. And generally they last somewhere between 6 months to 1 year. And Mickey button, putting directly Mickey button as a first setup using push technique, instrument would cost around 20 to 25,000, and rest endoscopy charges and hospitalization as per the setup where you are doing that. And when come to complications, major complications are peritonitis, perianal abscess, necrotizing fasciitis, and I had one case of colonic perforation because child had some scoliosis, kyphosis. Child was arching even after general anesthesia. Sometimes colon can come in between. So, and major bleeding can happen, which is again not very common. So on an average, 5 to 10% children while placing PEG tube can have a risk, but extreme risks are peritonitis and colonic perforation, which is extremely uncommon. So minor complications like peristomal leak, tube clogging, tube deterioration, granulation, these are all the commonest minor complications which can be handled easily. So these are all the series. So regarding maintenance, there was a question on how to monitor PEG tube. So basically, clean the gastrostomy site and the external fixation or device. And you need to release it, loosen it, and just rotate it, clean around the wound site, and then you can refix it. You can push 2 or 4 centimeters of the tube inside and turn it so that there is no adhesion or a necrosis, and then pull it back with gentle till the time you get a gentle resistance, and then fix it with the fixator. And you may need to put some. You may need to put
Mansi,
some.
can you mute Dr. Prashant?
Yes.
Yeah, sometimes you need to clear this tube because clogging is another one of the important issue that can happen. So after each feed, you can flush with the saline or a drinking water, or sometimes you may need to put carbonated drinks or baking soda to clear the tube. So this is about how to maintain the tube. And then initiation of tube feeds. Start with small volume based on the age of the child where you are placing PEG tube. And then if intermittent feeding is not tolerated, you can go for continuous feeds, then go for bolus feeds, and then then gradually increase the feed volume. Generally, it takes around 5 to 7 days to achieve almost 80% of required feed volume. And then once you reach that, generally we don't have any issues. Initial problems are reflux, stomach pain, and vomiting. So child is not tolerating the feeds. But once child gradually tolerate feeds, generally we have seen that long-term outcomes are excellent. And initially there is a lot of resistance from parents that I mean, like the moment we say that there is some surgery, some puncture is being done or a tummy, so most of them refuse that. But on long term, I have seen most of the parents are very happy about the procedure because the feeding, the time for the feeding, aspiration risk, and kind of feed that you can give will enormously improve after placing PEG tube. And there was a question, comparison between PEG tube and gastrostomy. So PEG is again a endoscopic gastrostomy, and conventional is surgical gastrostomy. So PEG is being minimally invasive. I think the recovery and procedure duration is short, so the complications are also less. Only time when I suggest to go for directly surgical gastrostomy is when you want to combine with anti-reflux surgery, especially in children with severe GERD who are presenting with severe regurgitation and recurrent aspiration pneumonia. So then removal can be done easily. PEG tube removal and replacement can be done easily. And there are not much complications. So basically, to summarize, PEG tube is a very good option for a children who has recurrent aspiration or feeding difficulties, where parents unable to feed the child, where nutritional requirements are not met. When you want a long-term feeding, PEG tube feeding is very useful with minimal complications, and can be placed for long term without much risk. So that's about PEG tube. If there are any questions, I can take on PEG tube. Anything else, Dr. Raju?
Raju, you're mute.
That covers most of the questions you are already discussed about constipation and GRD. So any comments, any questions, others they can ask a
I
question
think
related to PEG tube.
I will ask Dr. Lokesh to make comments on the entire session. And Dr. Nagendra, only one question. When do you ask for an open gastrostomy? So now everybody's doing PEG, but in what situation you yourself in your practice? Because we ask for open gastrostomy at times in certain cases who are very fragile. And also, let me just ask this from your experience. Yeah. And then Dr. Lokesh, I'm requesting you to summarize in your comments, please. Yeah, Dr. Nagendra.
Yeah, Dr. Shafali, there are basically two indications. When there is a severe GRD, and you know that through the endoscopy or through the contrast studies, that you know that there is a hiatus which is also associated. Basically, when you think that child requires anti-reflux surgery, you took all medical management for GRD, you thickened the feeds, positioning is changed, and despite all these things, there is a lot of reflux. It is causing even complications like aspiration pneumonia. So in this case, doing PEG tube may sometimes worsen reflux. So in this situation, doing anti-reflux surgery along with gastrostomy, that is the way forward. So in this case, I would suggest to go for open or laparoscopic or surgical gastrostomy. And second thing is, whenever there is a severe kyphosis and scoliosis, there is a abnormal anatomy of the stomach. So that times it becomes very difficult to get a very safe window to do the PEG tube insertion. In this case also, I would suggest open gastrostomy. I think these are the two main indications where open gastrostomy is suggested.
Thank you. Can you stop sharing the screen so that we can look at the screen?
Yes.
Everybody. Thank you so much. And thank you all for staying so long. It is in very, very long, and some of our panelists had to leave. Dr. Lokesh, I would like to request thanks for all those who are staying on. Dr. Lokesh, can you please make your comments? Please?
Yeah, sure. I think that is a very essential seminar what we had, because caring for children with complex neurodisabilities involve a team. I think as an individual, we can do only so much, and we as a team have to be able to cater to these families, especially if it can be done under one roof, that will be even much better. And looking after the visual aspects, which has been covered quite well, because lots of children, unfortunately, we still have to manage NHVI, which is the most common cause for visual impairment in India, and apart from cystic encephalomalacias and cystic PVLs, so apart from the genetic ones. So that is very important aspect, because taking them on early and then trying to help them out. So because the visual maturation, if it doesn't happen before 3, it is very unlikely that they will develop a good vision. Similarly, taking care of the nutrition, avoiding the aspirations, and optimizing the nutrition so that the neurological problems will not worsen and avoiding the aspirations at whatever the possible ways and improving the sleep. All these things have to be optimally done and timely. So this helps a comprehensive care of these children and the families as such. Thank you for this opportunity. Thank you.
Thank you very much, Dr. Lokesh. Actually, if you want Raju and Tanshu, can you see any questions which have to be answered? Anything pressing? Oftha was answered, right? Most of them have been answered. If anything has not been answered, I think all of them have been answered, right?
There are a few questions like role of paracetamol in management of CP. So we'd like to answer that.
Raju, answer that.
No, that I think that is not related to
Sorry,
current.
I'm sorry, I'm mistaken.
Yeah, but you want to say that you can make this statement. We are not using paracetamol in the medical management of CP. Yes. Yeah, we have not been doing the VSS scan. And rest all, I think, ruling, I think, has been said completely right. And I think most of the things have been covered, right?
Right.
Yeah, and
Yeah,
you know,
yeah,
submandibular duct ligation. Also, we have also tried, as was also mentioned. It's, I think, very correctly. Yeah, which vaccines for pneumonia you can say.
Madam,
Raju,
submandibular duct ligation should not be done. It should be transferred to the inferior pole of the tonsil.
Yeah. I mean that.
And
Sorry, it should be transferred.
sublingual gland is to be excised.
Yes, that is, we should call it ligation. I mean, it's
transfer.
Diversion, transfer.
Diversion.
Transfer. Yeah, definitely. Yeah, you're
And
right. Absolutely right.
There's another question.
Yeah.
There's another question asking how often do we offer Botox injections in India?
Yeah, Dr. Meghanand.
Sir, what is the question? How often?
You offer Botox.
Botox.
See, for the orthopedics, we had the last session. Today is
our
only ENT
neurology
reply.
colleagues are
for drooling.
Very frequently.
Yeah, only drooling, Dr. Meghanand, only for drooling. Orthopedics we had last time. We've already done the orthopedics part last time, and today is just asking about drooling. Yeah.
Drooling, I mean, see, they are having the Botox with them, so they are giving for the submandibular gland and parotid.
Yeah. So, but he's saying how frequently, whoever they are referring. So neurologist must be referring.
Usually the first dose will be after 6. The second dose will be after 6 months, and then onwards the interval increases. And over a period of 3 to 4 doses, the glands shrink and they may not require any more further doses.
Yeah, that is there. And but you know, in certain cases when they're not, it's too much, then the duct transfers is that is what
that is
being
a
done,
last resort.
Last resort, because this we had started doing this duct transfer thing long before Botox came up, you know, that much. So that was, we did it long back. So I mean that in those who are not affording, we're trying to make a. I think everybody can give, all the panelists staying on can give their messages. I think Dr. Roshan, you can give the message, your take-home message. And, you're mute.
Sorry. My take-home message would be to just be very proactive when it comes to nutrition. Worrying about or just talking about malnutrition really is not going to help your children. So please be proactive with sending them to the dietitian who is equipped to give in the time that is required for the counseling of the parents, because as I think
so basically a pediatric neurologist should be sending more involving nutritionists more. That is the what, right?
Take away.
Yeah, thank you. Yeah, thank you, Sanjukta.
I think just reading up the consensus statement, I found the use of tobramycin some time back, and I've used it. So for my respiratory colleagues and for those who are dealing with very bad cerebral palsy cases, I would consider using tobramycin as recommended in the consensus statement. So that will prevent recurrent respiratory tract infections in those who are prone to pneumonias. I mean, that's one thing. The other things, obviously, everybody knows and everybody probably applies in their day-to-day practice. But another thing I would like to highlight is the respiratory problem is the probably one of the highest cause of morbidity and mortality in cerebral palsy patients. So vaccinations is very important, and prevention of tobacco smoke inhalations within the family, and vaccinating all family members and all other children in the family are very important.
Dr. Meghanand.
Yeah, from ENT side, I think doing impedance audiometry, autoacoustic emissions at regular intervals, identify the middle ear effusion and treat it. It's quite common, and 20% of the children do have the this problem. And a good number of patients do have significant adenoids, and treating the adenoids many times reduces the drooling. Once the mouth is closed, the drooling might come down. So these are the two simple things we should not miss, and they're quite common. Thank you.
And somebody had asked those vaccines, we're giving that varicella, pneumococcus, and influenza. I think now COVID also maybe put that in addition, right? Viniti?
Yes, Dr. Shefali.
Take home message.
My takeaway would be to start early and to work together as a team. And at the same time, to really focus on how they understand individuals with cerebral palsy, how they understand their cognition, because that's really important in terms of really thinking about a good management plan in terms of their what and how we're going to really work on their communication skills. We need to focus on their understanding so we can better support them in terms of their expressive communication, whether we are using a picture-based communication device or whether we are using any other tech aid. So we need to really ensure that we focus on how they understand people around them and what their level of understanding is. Yeah, that's all. Thank you.
Thank you. Thank you. Dr. Nagendra, I know we are 29 minutes behind. I mean, beyond the time. I mean, at least one time message. Yeah. Our moderators are had to be more efficient,
I know.
right?
My topic was cut shorter to peg tube insertion. Well, GI symptoms almost constitute 90% of, almost 90% of children with cerebral palsy have one or the other form of GI symptoms. GERD is again one of the important complications to the tune of 70 to 80% in these children. Again, early identification of GERD and management is very important to prevent complications such as otitis media or recurrent aspiration. And then, and some children do have gastroparesis associated with GERD because of the neurology that is involved, and also kind of feeds that child is taking. So proper management of feed intake and identifying the complications and treating the GERD medically and even surgically is very important. And when coming to peg tube insertion, again, peg tube should be considered in children wherever it may be nutritional causes, it may be regurgitation. Some parents are they get exhausted while feeding due to long time that is child is taking, which is affecting the child nutrition, dental issues. So in these conditions, peg tube placement is very safe until unless there are some absolute contraindications. So peg tube should be considered, and it is easily doable daycare procedure, but you need 3 to 4 days hospitalization for the management of post peg tube placement, basically feeding and monitoring the feeds. And most of them in 5 to 7 days get adjusted to peg tube. And then constipation is again one of the commonest complication we see. And most of the children, quality of life is severely affected with the constipation because of the colicky pain, and also the hard fecalids that are going to impact in the child intestine. And sometimes it is very difficult to take it out, and we need a early identification and optimal medical management. To most of the times we can manage with medically, and once you disimpact the stools, child may start taking feed. In fact, so many times parents say that child is not taking feeds, and because of this colicky pain and associated with constipation can add to all these complications. So early identification and properly treating the constipation And polyethylene glycol is nowadays first choice of constipation treatment. And only when you are unable to give it, lactulose is a second choice. And these are excellent, safe on long term. You can use it as long as you want. Basically, you want to keep child child gut clear and also comfortable. Once the pain sets in, fear sets in, the child start gonna hold the stool, and then again and again you need to do the disimpaction. So I think these are the messages from a gastroenterologist perspective.
Thank you so much. Mahesh, would you like to add something?
CP is a to be managed by multi-resource team. Wherever you are, you need to form a team. Like you not have all the specialties in your setup, but definitely you can take help of the other department, have our own team, and make use of all the team members to manage this student comprehensively.
Thank you. Anybody else wants to add from the SIG? Anybody wants to say anything? Can unmute yourself and say. Because we are very much behind time, but anybody wants to say anything? If Ditanshu and Raju, anything last moment?
We can wrap up. It has been a great session. Yeah.
Raju, anything you want to say?
Yeah, mainly you should take early consultation from this team. So for early intervention will be more useful rather than referring later.
Absolutely, absolutely. I think we have to think about everything that is very important, and that's why the theme this time is together. So we have to be working together and together between different professionals and all, and that's how we have to look at the whole thing. And thank you so much, all of you, for joining and sparing your valuable time and staying on. Those who stayed on till the end, we're really grateful, and we look for more partnership. And maybe when we'll be developing some consensus guidelines, we will again request you guys to come up with your experience and do forward. Right? Thank you so much. And I think we can wind it up. Yeah. Thanks a lot. Bye. Good night.
Thank you.
Good night.
Bye-bye.
Bye. Good night.
Good night.
Good night. Good night.
Good night.